Hello and welcome back to my channel on infectious diseases. Today, we will discuss osteomyelitis, a complex and serious infection of the bone that can lead to significant complications if not properly managed. This topic is crucial as osteomyelitis requires an individualized treatment approach based on various factors such as causative organism, bone involvement, vascular supply, and comorbidities. Osteomyelitis is an infection of the bone that results in tissue destruction and, in some cases, long-term debilitation. It can be caused by a wide range of bacteria, fungi, and even viral infections. The severity of osteomyelitis varies from localized infections, such as those arising from a tooth abscess, to extensive cases involving the vertebrae or long bones. There are two major classification systems used to categorize osteomyelitis. First is Lee and Wald-Vogel classification, which differentiates cases as acute versus chronic and hematogenous versus contiguous spread. This image shows features of 5 sequential stages of acute osteomyelitis as well as the chronic osteomyelitis. This picture shows that infectious organism can reach the bone either via blood vessels from a distant focus of infection in the body, for example, embolized fragments from infective endocarditis vegetation, or via contiguous spread from overlying muscle or skin infection. The second classification system is that of Cierney and Madder, which classifies long bone osteomyelitis based on infection location and extent into 4 stages. Stage 1 is medullary osteomyelitis, Stage 2 is a superficial osteomyelitis, Stage 3 is localized osteomyelitis, and Stage 4 is diffuse osteomyelitis as shown in the picture. Patients are further classified as A, B, and C as normal host, local or systemic compromise, and treatment morbidity worse than the disease. Now, what is the etiology and pathogens? The primary bacterial culprit in osteomyelitis is Staphylococcus aureus, including methicillin-resistant strains. Other common organisms include gram-negative bacteria like Escherichia coli, Klebsiella pneumoniae, and Pseudomonas aeruginosa. Coagulase-negative staphylococci are often associated with implants and foreign bodies. Fungi like Candida and Aspergillus. Mycobacterium tuberculosis is a common cause of vertebral osteomyelitis, especially in developing countries. Infections can arise from trauma, surgical implants, or hematogenous spread from distant foci such as urinary tract infections or bacteremia. Coming to the epidemiology, osteomyelitis affects 0.1 to 1.8% of healthy adults, with much higher rates in individuals with diabetes. Up to 40% of diabetic foot infections progress to osteomyelitis. The rise of MRSA has made treatment more challenging as these infections tend to be more aggressive and require different antibiotic regimes. Globally, the etiology of osteomyelitis varies. In resource-limiting settings, tuberculosis-related osteomyelitis and brucella infections are more common, while in industrialized countries, post-surgical and implant-associated infections are more frequent. Osteomyelitis develops when an area of bone has compromised viability, blood supply, sensation, or edema. Factors such as trauma, vascular disease, and systemic illnesses like diabetes contribute to its development. Staph aureus produces toxins and enzymes that damage tissue and evade immune responses. Biofilm formation, particularly by coagulase-negative staphylococci, allows bacteria to persist for years, especially on prosthetic joints. Hematogenous osteomyelitis often affects the vertebrae and is commonly linked to urinary tract infections. Diabetic neuropathy worsens the disease by masking symptoms, leading to unnoticed progression and the need for amputations. Early diagnosis is the key to preventing complications. Symptoms of osteomyelitis may include localized pain and swelling, fever and chills, drainage from an open wound in chronic cases. Diagnosis involves history and physical examination, with history of any previous trauma, infections, surgeries, or prosthetic implants. Lab tests like elevated ESR and CRP. Leukocytosis may be seen in acute infections. Imaging like X-ray can show bone destructions but may take weeks to become apparent. MRI is best for detecting early infections and soft tissue involvement. Bone biopsy and culture are crucial for identifying the causative pathogens. Treatment of osteomyelitis is multidisciplinary, requiring collaboration between infectious disease specialists, orthopedic surgeons, and microbiologists. The choice of antibiotic depends on the pathogen and resistant patterns. Methicillin-sensitive Staph aureus requires treatment with nafcillin, oxacillin, or cefazolin. MRSA requires treatment with vancomycin, daptomycin, or linezolid. Gram-negative bacteria are treated with ciprofloxacin or third-generation cephalosporins. For anaerobes, we give clindamycin or metronidazole. Antibiotics are typically given intravenously for 4 to 6 weeks, followed by oral therapy in some cases. Surgery is often needed, especially in chronic or refractory cases. In the form of debridement, that is, removal of the necrotic bone and infected tissue, abscess formation requires a surgical drainage, and amputation is sometimes necessary, particularly in diabetic foot infections. For stable patients, outpatient parenteral antibiotic therapy allows IV antibiotics to be administered at home, improving quality of life and reducing hospital stay. Complications of osteomyelitis include fracture due to weakened bone structure, septic arthritis if the infection spread to the joints, chronic osteomyelitis with recurrent flare-ups, and amputation in severe cases. With early diagnosis and aggressive treatment, outcomes are generally good, though reoccurrence remains a concern. Preventing osteomyelitis requires infection control measures including proper surgical asepsis to reduce post-operative infections, early management of bacteremia and skin infections, good diabetic foot care to prevent ulcers and bone infections. Osteomyelitis is a serious but manageable condition when diagnosed early and treated appropriately. Understanding its pathophysiology, risk factors, and treatment options is crucial for medical professionals. That's all for today's session. If you found this information useful, don't forget to like, share, and subscribe for more medical content. See you in the next video.